There is no known cure for COVID-19 at the moment, and most experts believe that a vaccine is at least 12 to 18 months away. But some hope has emerged in recent weeks, with doctors turning to treating patients with blood plasma. So what does that mean? Now, when an infection strikes, the body starts making proteins called antibodies that are specially designed to target that infection. These antibodies then float in the blood of survivors, that's specifically the blood's plasma, for many, many months and many, many years as well. Infusions of antibody-rich plasma from patients who have had the disease and recovered are being used to treat others who have COVID-19, and it seems to be working pretty well. Doctors in China started doing it and met with success, and now doctors in the US are trying the same. However, there is a note of caution. Last week, 5 patients in China who got the plasma all improved their condition a week later, but they had also received other therapies along with the blood plasma. So a lot of doctors are saying that until there are more studies on this, we won't really know if the plasma alone helped them to recover. Now, the use of blood plasma by itself is nothing new. It was used to treat the 1918 flu pandemic, 1957 as well as SARS, H1N1 and Ebola. In India, today, Kerala has got approval from the Indian Council of Medical Research, the ICMR, to test plasma transfusions in very critical patients. So could this be the game changer that we are looking for? Joining us straight from Maryland in the United States tonight is Dr. Fahim Yunus, who is the head of infectious diseases, the chief of infectious diseases at the University of Maryland School of Medicine. Thank you very much, Dr. Yunus, for joining us on NDTV. Lots of interest. We're following you very closely, and you know what you have to say. Tell us why you think that this could potentially be something that, in the short term anyway, could help patients who have COVID-19.
Thank you very much for having me. As you just very rightly said, a vaccine is probably 12 or 18 months away. So we need to build a bridge from here to there so humanity can pass through that bridge and we can save a lot of lives. We have 3 or 4 different drugs that we are trying, but all of them are also experimental. The key word, I believe, for plasma treatment I would use is it's promising. I would not say that it's proven. I would not say that we know 100%, but the data so far is promising. And this is a game of inches. We have to gain inches wherever we can. And I believe in a time when the tests are in a shortage, personal protective equipment is in shortage, plasma is one resource that perhaps is an adequate amount and will continue to increase as more and more people become infected, become immune, and are able to be donors. So that's where the promise lies.
There are, of course, doctors who are being cautious about it as well, saying that, and you're being cautious as well, many say that it requires more study as far as the COVID-19 is concerned before we can say effectively that this is the cure that we're looking for. So, what are the notes of caution that you also would strike as far as the use of blood plasma is concerned, though I see that it's gaining a lot of interest in the US in particular at this time?
Exactly. I think the most important thing people need to remember, once again, it's promising, it's not proven. And number 2, it's a sophisticated procedure. We can't have people just open up a shop on the corner and say, hey, come donate your blood and I'll cure your COVID. That's my worry. We cannot have it unregulated. We need to make sure, because there are some unknowns, how much antibody is enough to cure someone. And we also need to make sure that that plasma is negative of other viruses. Anytime we infuse plasma or blood into another body, there is a potential that you may be giving them another infection that was silently hiding in that plasma. So there are certain procedures that we need to follow. We need to make sure that the patient is safe and that plasma is safe to be infused. But of course, the other part, as far as no studies and no proof, I really think this may be the opportunity for us to study it on a large scale, which probably did not happen during SARS because the SARS impact was much smaller. This time we see the impact is already in the millions of people, and with hundreds of thousands of people potentially immune at this stage who've recovered from COVID. I think that sample size is already 300,000 people or more. So this is our opportunity to study it. And perhaps, as they say, in every crisis, there's an opportunity. I hope that this is the opportunity in this crisis.
But as you said, it's not that somebody who's recovered from COVID-19 can just get up a week later, go to the hospital and say, I'm giving you my blood here, cure somebody. There are lots of boxes that have to be ticked off, other viruses, other infections. And also, I guess you also need a large number of people to have recovered in order to be able to use that plasma. And I don't know how the numbers are looking in the US at the moment.
Yeah, so I think the things we need to be aware of. One, the patient must be at least 2 weeks beyond their health. So if I got COVID, now I've fully recovered. The day I have full recovery, I got to wait at least 2 weeks. Then I got to get another test of COVID to make sure I'm COVID negative. If I cannot get a test, I got to wait 4 weeks. And then that has to be done in a sophisticated fashion, like I said. But here's another caveat. We have to temper down our emotion and make sure that we are data driven, because there's a lot of emotion. A lot of this is good emotion. We also have to make sure that the most deserving patient gets the plasma, not someone who's close to me, not someone who I want to save, but someone who deserves to be on a certain criteria. So we have to build all those criteria. We have to have it regulated.
What would that criteria be? Would it be, absolutely critically ill patients?
I think that's a much longer conversation, and it will vary from country to country, from institution to institution, and from resources. Once we have hundreds of thousands of bags of plasma, I think those criteria can be much loosened. But if you're dealing with 10 donors and potentially 1,000 people who would like to have that donation, that's going to be a much difficult ethical conversation.
On this issue of antibodies, though, Dr. Yunus, we're reading a lot, in the last few weeks about doing these antibody tests, in the population to see who may have developed an immunity to this disease, and then therefore could potentially even go back to work at some point. Tell us if that is foolproof as well, because again, from what one reads, we don't know whether there is long-term immunity to COVID-19 yet. People might have immunity in the short term, but we don't know whether this infection would come back. So how effective are these antibody tests, which some countries are now, doing?
I think that's a great question. And the reality is medicine is a very humbling profession. I've been in this profession for 20 years. And one thing I've learned, you stay humble, you never say never, because things are complex. This is a virus that's 3-4 months old. Remember, influenza is over a century old. We know that virus really well. So we've gotten just 4 months to study this virus. There are a lot of unknowns, and you're hitting on some of those unknowns. We believe that someone who recovers completely after coronavirus infection likely has antibodies. But whether those antibodies will last 3 months or 6 months or 6 years or lifetime, we don't know that. What level of antibody is enough to protect me and for me to become a good donor? That answer has not been figured out yet either. But at the same time, we are trying not to use the antibody test to start diagnosing people. The PCR current test is still the best option for that. However, antibody will be hugely benefit, I believe, in developing countries where we've had challenges with testing up front. And what if X percentage of people have already recovered from it? I think that will add a data-driven ray of hope that we all need.
I was also reading one of your tweets, about, as you put it, a myth that developing countries have less COVID patients because of BCG vaccine immunity. We had one of the authors of that BCG report on our show just the other night. So you disagree with this BCG theory. Can I ask you, though, if you do disagree with that, then how do you explain, for instance, what appears to us at the moment to be actually a far less number of cases in a big country like India with a population of 1.3 billion? Now, is it only that we're not testing enough, which we clearly aren't, but as some have pointed out, by now, we had our first case back in January, 30th of January. By now, our hospitals should have been then overwhelmed with people with respiratory problems. And, thank goodness that hasn't happened either. So how do you explain, in your view, the trajectory that India is taking, for instance, at this time?
Yeah, that's a fascinating question. I think, first of all, let's agree, we are all on the same side. I'm not opposing, I'm not in disagreement. We're all on the same side. We're all trying to do the best for humanity. Reasonable minds can disagree. And I think if I'm wrong, you win. Humanity wins. But what if I'm right? That's my worry. If I'm right, millions of people are at risk. So here are the reasons why I believe we should not fall for these things. Number one, I think it's a good correlation. It's not a causation. And as I've been saying, if in the month of January you see an uptick in the car accidents in New Delhi, you can't just say, oh, in January car accidents go up. Because when you look deeper, maybe there is more smog in the air, and because of that lack of visibility, that's the underlying cause. January is just a correlation, not a causation. So I think when you look at Poland, where they've had been doing BCG vaccines, even in England, up until 2005, they were giving BCG vaccines. In Iran, they've been giving BCG vaccines. I do not see that same trend. And yes, people very quickly will use in one sentence, yes, we are not testing, but I think that's a very big hump. That's an elephant in the room. Countries that have diagnosed more cases have tested nearly 2,500 people per million. And in India and Pakistan, countries that are developing, they're testing 100 to 200 per million. Your other question about not seeing enough morbidity and mortality in the hospitals. Now, this is where, again, we're all on the same side. I wish I'm wrong and everybody else is right. My fear is that this virus goes exponentially and it remains quiet. You know, it's like a game of chess. Remember, you put one grain on the first box and the second and the third. At some stage, it will get so exponential that if we waited until it started showing up in the hospitals, it gives me goosebumps. It'll be too late. So yes, I know it's not happening right now, but maybe it's starting to happen in smaller pockets of our villages, and it's happening out there, but we just don't have a very good infrastructure to capture every death. I don't know how many people are dying with quote unquote pneumonia, but they are COVID. How many people are dying in a hospital today because we are thinking they had a heart attack, but coronavirus can cause a heart attack as well. So there are so many confounding variables that as a scientist, I hesitate to give millions and billions of people that sort of reassurance based on a correlation. But at the end of the day, we're all on the same side. I'm as well-wisher of humanity. Trust me, I would love to be wrong.
But I think the good thing is to be cautious. And could I finally ask you, though, about the anti-malaria drug that President Trump has been talking about, which India is now going to export to several countries, including the US. What do you think of its efficacy in treating critically ill patients? Again, there's been a lot of difference of opinion on that. But is it something that can be used in critically ill patients successfully?
So I'll tell you, I think in the US, it is being used in critically ill patients. Once again, it needs to be used sophisticatedly under observation. We make sure that patients' heart rhythms and they're not prone to any adverse effects. I would not recommend people using it prophylactically, which means let me just start taking a pill a week and it'll prevent coronavirus. I think that'll be a bad idea. As far as the results are concerned, anytime in a situation like this, which is unprecedented, I think we typically go by our first Hippocratic oath, the principle, first do no harm. When we see that there is no harm in a drug or we can mitigate the harm and there is some potential benefit, I think it's reasonable grounds to start using it. We in the US are using it significantly, I would say. Where the outcomes are, how good or not effective it was, we will know in a year or two. But we cannot wait. Our patients in the hospital, it's very painful when I have patients, very, very painful to go in a patient's room and tell their family, there's nothing I can do for your loved one. So I think we come from a place of compassion. And like plasma therapy, like these antibody tests and chloroquine or azithromycin or remdesivir or their other drugs, all of these to me are small bridges that we're trying to make up until we get to a vaccine or a good treatment. It's really a game of inches. Nothing is going to give us yards here. We are going to have to gain small inches with every intervention. And we're hoping that as one mankind, we can do that kind of good for all of us, for our loved ones everywhere.
Dr. Fahim Yunus, thank you very much for joining us on NDTV this evening with your perspective there. As I said, we're watching you with a lot of keenness all the way here in India. Good luck to you. And hopefully this blood plasma is something that can work in more and more people. Thank you very much.